from the WHO. I'm Mike Turner. I'm a member of the team that works on snakebite in the Geneva office, and it's a pleasure for me to be your moderator for this session. In fact, it's the first of two sessions. They're identical in the general style and format, but we've deliberately tried to run two sessions. For those of you who are east of Universal Standard Time, we hope that this is a more convenient time. At least for many of you, this will be in the working day. And then later on, we will be running an session for those of you who are west of Universal Standard Time. Again, so that most of you can join us during the normal working day. So the agenda, I think, will be displayed, I hope. What we're going to have is what I hope are going to be a set of really interesting presentations, short, sharp presentations, if I might remind our panelists. And then we will have a brief panel discussion. Okay, to get us started, David Williams is from the WHO Regulation Pre-Qualification Department and is our leader and coordinator of the Snakebite Initiative in WHO Geneva. David, over to you.
Hi, everybody. I'll just see if I can get this presentation up on the screen. It's a little bit tricky here because I've only got one screen to run it from.
We can see your screen, David.
Yep, no worries. I'm just going to try and get rid of all of this other guff.
Yep, we're fine.
Okay. Sorry, I can't see the screen because
we've got your first slide up, David.
Yeah, okay, good. So what I want to talk about briefly this morning is improving access to antivenom treatments for snakebite and some of the work that WHO is doing. Is everybody else seeing that panel of video images in the middle of the screen?
We're now on slide 2.
Okay, there's nothing obstructing your view because I've got a Zoom window right across the front of my screen, so I've got no idea what you're seeing.
No, we don't see a Zoom window. We literally see slide 2.
Okay, great. So WHO has developed a roadmap back in 2019 to try and reduce the burden of death and mortality and morbidity and disability from snake bites. We have a number of strands to this, engaging in empowering communities, the strengthening of health systems, building of partnerships, and ensuring safe and effective antivenoms. And this is the thing that I want to focus on at the moment. Some of the work that we're doing involves the development of target product profiles, which I'll talk about shortly, the risk-benefit assessment of antivenoms in various regions of the world, the potential development of stockpile project to make antivenoms more accessible, and alternative pathways for the clinical evaluation of snake antivenoms. So to plough into this quite quickly, I'll first talk about target product profiles. Now, for those who are not really familiar with them, these are specialist documents that give advice and information and guidelines to regulators, to manufacturers, to researchers that are looking at the development of various types of products for the treatment of snake bites. We have a number that we're developing, including some for conventional animal-derived plasma antivenoms, small molecule inhibitors, and also for engineered antibody products. WHO established a 18-member technical and scientific advisory group to pursue this work. And as we develop the TPPs, we publish them on our website for public comment. We take all those comments on board, and then it goes back to the committee to elucidate a final version, which eventually will be published at the link that you will see on the bottom of this slide here. And the idea of these is to give these various groups the sort of guidance they need to develop products that are much more suitable for the environments in which they're going to operate. So they cover a wide number of areas. They define target populations and working ranges, the countries, for example, in which products are appropriate, indications for use. The manufacturing side, they will explore the types of immunising venoms that need to be used, the type of active pharmaceutical ingredient and its constituent parts, and then also the performance, both preclinically and clinically, in terms of effectiveness, safety, tolerability, the risk of drug interactions, and so on. And we've also, because these are public interest TPPs, we also touch upon areas such as cost, supportive and adjunctive therapies, the need for health worker training and education. Moving on from that, the other really big piece of work that WHO is doing around antivenom treatment is the risk-benefit assessment of snake antivenoms. Now, this is not formal WHO pre-qualification because many public manufacturers would not be able to meet those requirements. Instead, what we do is we evaluate whether or not the potential risks of using a product are greater than or less than the potential benefits of using the product, and come up with a decision that's based on what would be in the best interests of people who receive these antivenoms. It begins with a comprehensive dossier review by an independent panel of experts. At the same time, we conduct a very extensive investigation of the antivenoms themselves in an independent laboratory, and the WHO GMP inspection team goes out and actually conducts GMP inspections as for good manufacturing practice compliance at the manufacturing sites, and we include everything from the production of snake venom, the production of hyperimmune plasma in equines and other animals, right through to the final product being packaged and ready for dispatch. And all of this data will eventually go back to our independent panel. It's a technical advisory group that includes regulators, clinicians, epidemiologists, herpetologists, and people who are experts in antivenom production, and they will make a final decision. Those decisions have led so far to the recommendations of 3 antivenoms in sub-Saharan Africa: Equitab G, Antivitamin Africa, and Panaf by Premium Serums. We have a number of other antivenoms currently under assessment, and so far there's only been one termination that hasn't been brought back to us for re-evaluation. We look at a lot of different products from various regions. For example, at the moment, we're evaluating a number of Middle East and North African products from countries like Iran, India, Israel, and even a product from the United Kingdom. And from where I'm speaking today in India, we're currently in the middle of GMP inspections for Indian products by a multitude of manufacturers, and we also have another manufacturer in Pakistan that we'll probably take a look at. All of the results go up on a website, and I've put the link at the bottom. It's under the WHO's extranet and the PQ web, and that provides information about where the products are in the assessment process and what the outcomes are. Now, the other activity that's going on in the NTD department, which I'll talk about briefly, is the potential of developing a stockpile project to deliver antivenoms into areas where supply is currently deficient. And at the moment, we're doing modelling for 8 countries in West Africa: Benin, Burkina Faso, Cameroon, Chad, Ghana, Niger, Nigeria, and Togo. The aim is to have a recommended 2 products available to deploy, and the map you'll see on the right in a darker brown is showing the areas where carpet vipers are the highest risk, and the areas in pink show where other species of venomous snakes are at the highest risk. It's a very data-driven approach. It looks at a range of different things. In particular, we look at the various populations of snakes, their distributions. We combine ecological and environmental parameters. human population, agricultural and other activity data to elucidate risk maps to show where the highest chance of encounters with these animals are in areas where humans are active. And that gives us a baseline guide as to where it may be more important to deploy particular products. Based on that, we're also able to look at where people would have to travel to get to medical assistance in those areas. And so we can map out the areas where people have the longest to travel. Ideally, people should really receive treatment within the first 6 hours of a snake bite. So we can identify here areas where they are 4 to 5, 5 to 6, or even more than 6 hours away. And again, this helps us identify areas that may need to receive higher priority. Now, we can take the same sort of geospatial modelling and we can look at where the regional stores for antivenoms are, shown on the far right, for the far left for Togo, and map out how long it's going to take to get product from the place where they arrive in the country to those peripheral medical stores. And then beside that, in the middle of the page, we can also work out how long it will take to get the antivenom from the peripheral stores to the health facilities that they're going to go to. On the right-hand side, and I'm using an example of Chad, we've mapped, and it's very hard to see, I know, on this screen, but we've mapped where all the various health facilities are, and we've also mapped where people are at the greatest risk. So we can define how many people, for example, would be in a high-risk area of contact, in this case with carpet vipers, and be more than 6 hours away from a health facility. And of course, those are the people who are most vulnerable and the people that we may need to work with ministries of health to try and find a way to improve their access to these sorts of products. We've also taken the approach that we need to start looking ahead to the future. And the snakebite team are very interested in the potential impact of climate change. So in this example I'm showing you at the moment, we've mapped the current suitability of habitat for the black mamba in sub-Saharan Africa, whereas the yellow areas are the areas where they're most suitable. And all those little yellow dots you can see are actual specimens whose locations we've mapped. To the bottom left, we show where it's likely to be in 2050. And I guess to really reveal the impact, if you look at the main map, the areas in red and orange, particularly in southern Africa, are areas where it's very likely that we're going to see an expansion of the range of this species as climate changes, whereas areas that are in blue, such as around the Democratic Republic of Congo, some parts of Kenya and southern Somalia and Ethiopia, there may be contractures in range. In West Africa, it may be that the species does eventually extend into the eastern side of Nigeria as the climate changes, and there may be some small contractures in range elsewhere. We're doing this for all of the venomous snake species right around the world to give us a better understanding of what the resource needs in the future may be. Now, last of all, I just want to touch on a somewhat prickly question for some people, but it really is quite relevant to consider that at a time when millions of people are vulnerable, thousands are dying and many more are being left with disabilities because there's no safe, effective and affordable antivenom available. Is it really reasonable that we can afford the luxury of expensive, complex and risky clinical trials in such an environment? And for other types of use, WHO has identified alternative pathways. So, for example, there is an approach called MURI, M-E-U-R-I. It's the Monitored Emergency Use of Unregistered and Experimental Interventions. It's a framework that's been proven through the Ebola virus disease outbreak in 2014 in West Africa. And again in the Democratic Republic of Congo a couple of years later, was also used during the COVID pandemic to bring experimental products to the people who needed them much more quickly. There are certain prerequisites. There has to be agreement from national governments to issue that emergency use authorisation and to provide National Ethics Committee oversight. You need to have some good, robust preclinical data, an approved treatment protocol, and of course informed consent from the people who are going to receive the product. Compulsory case reports need to go to an independent data safety and monitoring board for progressive review. And with all of this happening, it's possible that products could actually be put into countries and used in real time, and we would gather information about them and evaluate periodically to either stop the use of a product that wasn't working or wasn't proving to be safe, or to modify the protocol to improve the outcomes of a product that is showing some promise. Now, our goal, of course, is to get more rapid access to existing, new and experimental treatments for people who currently have nothing. It's also about improving oversight of antivenoms, particularly in countries where at the moment there's no current provision for clinical trials encased in regulatory requirements for authorisation. And the current status quo is that completely untested products are just simply being marketed with no oversight whatsoever. Introducing this sort of approach, which may challenge some people, change is often confrontational, but at the end of the day, if it leads to a situation where we actually do improve the oversight, we make antivenoms available to far more people far more quickly, it could well be a very positive change. So it's something we're considering, it's something we're going to put out for public consultation, and we hope that when we do, that people will resist the desire to oppose it just simply because it doesn't represent the status quo. Consider it as a potential option that could actually make some improvements and hopefully make some adaptations that will move things ahead. So I'll stop there, Mike, just to give a quick rundown on our team. The NTD team is led by Bernadette Bella River, Kalshi Kanakegi, who's working with Bernadette, Mike Turner, who's our host today, and Bethany News is another part of our team. In health products, policy and standards, Dr. Yuyung Mariungasi works with the expert committee on biological standardisation to ensure that products like antivenoms are properly vetted. And in the area where I work, Carmen Rodriguez-Hernandez and I are responsible for aspects of regulation and pre-qualification of antivenom products. We have a number of external partners, key among them at the moment, Wellcome Trust, the Global Snakebite Initiative, and again, the group that are coordinating International Snakebite Awareness Day. Okay, so back to you, Mike.
Thank you, David. Okay, I think that's super. I hope that's helpful and informative for all of you. As you all know, WHO is a very big and diverse organization. Doing things in Geneva or based around Geneva is one thing, but it's really important, in our view, that all of WHO gets on board and tries to make inroads where they can as appropriate to their regions. So that's why we'd now like to have a couple of presentations from the regional offices. And we'd like to start off with the Sierra Regional Office. And Aya, I think you've got a presentation you would like to share with us. At least I hope so.
Thank you, Mike. Let me share.
Thank you, Aya. Yes, we can see your screen. Lovely.
All right. So thank you very much for this opportunity. So my name is Aya Yajima, the Regional Advisor on NTD in WHO Sierra. So I would like to share the overview and the way forward in our region. So WHO Southeast Asia region with 11 member states are known to record the highest incidence of snakebite in the world, with over 100,000 envenoming estimated a year. And also South Asia alone records the highest number of snakebite deaths in the world. Out of over 100,000 deaths estimated per year globally, 70% is estimated to occur in the South Asia. This map indicates available data from nationwide population-based survey on snakebite and deaths, and accurate measures of snakebite burden is lacking within the region, and many studies on national estimates rely on hospital-based or extrapolated local data. But we know that hospital-based data can underestimate the event rates, and local or regional data can overestimate event rates. So representative community-based survey is needed to provide more accurate national assessment of snakebite related events. We recently conducted a review of the national snakebite program in the region. According to that, While 75% of the countries have a national guideline on treatment and management of snake bites, only 30% have a national program for prevention and control of snake bite envenoming, and only 2 countries have a national strategy or action plan for the same. Particularly in terms of surveillance, out of 11 countries responded, only 3 have snakebite envenoming as a notifiable disease. And these are data reported at the national level. And in comparison with the data in the publication, the data is substantially underreported. Also, at the moment, no countries collect data on disability associated with snakebite envenoming. So in response to the launch of the global strategy, we also launched the action plan for prevention and control of snakebite envenoming in the Southeast Asia region 2022 to 2030 last year, with the goal as same as global goal to reduce the number of deaths and cases of disability associated with snakebite envenoming by 50% in the region by 2030. We have 3 objectives, and under each objective, we have a number of strategic priorities. The first objective is to prevent snakebite and provide effective first aid. And the priority is to engage, educate, and empower communities at risk on snakebite prevention and first aid care. The second objective is to ensure access to life-saving treatment and care, and priorities including strengthening effective pre-hospital care and rapid transport, strengthening healthcare and referral system capacity, and improving inventory management system and storage conditions of antivenom. And the third objective is to improve availability of quality, effective, and safe and affordable antivenoms. And priorities include optimizing production, procurement, distribution of locally appropriate antivenom, strengthening pharmacovigilance and post-market surveillance for antivenom, and strengthening regulation of antivenom quality, efficacy, and safety. We also have 3 supporting areas to effectively progress the 3 strategic objectives, which include leadership, governance, program planning and management, establishing surveillance system and monitor and evaluate progress, and to enhance regional partnership and multi-sectoral collaboration for advocacy, research, and innovation. So overall, we have a number of regional priorities and milestones in the coming years. These include national burden assessment for snakebite envenoming conducted in the region, having countries designate national focal point, and establishing and starting a reporting of minimum data set from countries to WHO, disseminating WHO toolkit for effective communication training, and having priority countries develop national strategy for prevention and control of snakebite envenoming. So since then, progress is gradually being made in countries, and I'd like to share just a few examples. India is definitely showing a strong leadership and commitment at the highest level, where national action plan is being finalized through a series of stakeholders consultation in the last many months. And more states are designating the state nodal officers. National Task Force for Research on Snakebite has been established, and also anti-snake venom serum is included as an essential drug list. Also, orientation and capacity building efforts are being made to the local level through the development of the protocol for snakebite management at PHC level, and also a series of virtual training on management and best practices conducted. And Nepal also has an excellent collaboration or partnership among the health ministries, NGOs, research partners, and WHO, and jointly developed a beautiful set of awareness activity materials, including posters, animation, and also radio program. So the progress is surely happening across the region, and next year we are planning to organize a regional meeting of stakeholders to review the progress and discuss the way forward to accelerate the progress in the region. Thank you very much.
Aya, thank you. Short, sharp, but really well focused, and lovely balance of ambition and practicality. Really looking forward to seeing what you develop over the next year or so, particularly at this meeting. Now we have next a presentation that was prepared for us earlier, for which we're very grateful, from Dr. Kazim Sanakula, who is the Wipro representative. Kaushi, I think you have the clip you were able to share with us. We can see the first slide, Kaushi.
Can you hear? The presentation is ongoing. Let me just see.
We have no sound, Koshi. Does anyone else have sound? Thanks, David. That's a shame.
Dear colleagues, my name is Kazim. I am the NTD team lead for the WHO's Western Pacific Regional Office here in Manila, Philippines. I'll try to briefly update you on the regional situation regarding snakebite envenoming and share with you some perspectives from the region. The Western Pacific region is a very diverse region where nearly 1.9 billion people live in 37 countries and regions, ranging from the steppes of Mongolia, China, and countries like Philippines, Vietnam, Australia, Japan. There are huge variations in the region. For instance, big countries like China and small countries like Tuvalu. But within these countries, there are huge subnational variations. It's a rapidly changing region in terms of socio-economic development, which is affecting the health of its individuals and communities in a fundamental way. In view of these changes, the regional office came up with its vision, which is called For the Future, and it guides the regional office response in the health sector. Reaching the unreached is one of the core regional frameworks which guides the NTD work, and since the snakebite envenoming is a part of NTDs, this is guided by reaching the unreached, which basically means that there are of the most vulnerable unreached people who suffer from NTDs, including snakebites. Snakebite envenoming is a significant issue within the region. Efforts are underway in different countries to estimate incidence and prevalence. However, as of now, there are huge gaps in terms of the estimates of incidence and prevalence across the region and within the countries. However, there are some countries which are high risk, such as Papua New Guinea, other countries like Vietnam, Cambodia, and as I mentioned earlier, there is a huge variation within the countries. For instance, in some countries, the incidence and prevalence is very different in rural areas and then mountainous areas than plain areas or urban areas. So those variations are also there. The region has several species of venomous snakes which are responsible for envenoming. These include vipers, for instance, Russell's viper, elapids, for instance, king cobra, and sea snakes. In terms of health systems, which is a basic need for the health sector response against snake bite and envenoming, there are serious issues. For instance, a small country like Vanuatu, where there are nearly 200 health posts, and those health posts are dependent on community health workers. However, the presence of community health workers and the capacity, this really affects the access to health services, including access to treatment of snake bites and access to antivenom. There are several challenges facing snakebite envenoming in the region. I can go through all of these challenges one by one. However, I would like to mention the key challenges, which are common across other regions also. However, I will quickly go through the most important ones, which include mapping, data, and surveillance of snakebite envenoming. The community awareness and mobilization are the challenge. Availability of anti-venoms, which is a classic challenge. Health systems and access to essential services. And also in view of the socioeconomic changes in the region, the pockets of the unreached populations. And across, these are affected by the lack of commitment and the required finances. Thank you very much.
Thank you. I hope you all found that as informative as I did. It's been really interesting just in 2 presentations, just noticing just how diverse countries are in terms of the disease burden they have, the problems and the needs. And yet there's a commonality that comes through them all. And one of those commonalities is the need for better epidemiological data. And that really comes home in the next presentation, which Kaushi is going to show us, which is from the WHO Eastern Mediterranean region. It's a presentation that Dr. Ali Shallah has put together, where they're specifically trying to improve their understanding in their region of the epidemiological burden of snakebite envenoming. Kaushi, next presentation, please.
Hello, this is Ali Shallah, and I would like to present the findings of a research project conducted by the Information Systems for Health Unit at AMRO in collaboration with the NTD unit. Snake bites and snakebite envenoming have received little attention in the Eastern Mediterranean region. And it is safe to say that data are often limited to absent for many countries. This is despite the fact that EMR countries host more than 50 medically important snake species. This was the motivation behind this project, which aimed to explore and develop recommendations to integrate data on snake bites into routine health information systems in EMR countries. Our methodology comprised a scoping review, followed by qualitative key informant interviews. As the qualitative interviews are still in progress, the findings presented here are mainly taken from the scoping review element. The review looked at published and gray literature from the year 2000 to 2023. We ended up with 196 records, and we believe that this is a relatively high number of publications. However, more than half of these publications focused or concerned 3 countries only. These were Iran, Morocco, and Pakistan. For most of the other countries, data were often limited or sometimes no data available, as in the case of Syria and Bahrain. We further extracted data on burden, species, and antivenoms. For instance, burden data included number of bites and deaths, permanent sequelae and disability, socio-demographic profiles of victims, and national level data in terms of incidence and case fatality. We found that disability was poorly characterized and quantified in all countries. On a positive note, 6 countries in the region collect and collate data at the national level. For species, identified snakes belonged to 30 species, with Cerastes cerastes being the most commonly cited species. Lastly, when it comes to antivenoms, Half the publications did not give details on the antivenoms used. Those that did documented several challenges in use, from shortages in supply, with antivenoms being administered below required doses, to over-administration or universal administration even in the absence of envenoming, as per some studies from certain countries. There was also the issue of antivenoms being not specific to the offending species, according to some studies from 7 countries. Finally, arriving at our takeaway messages. While evidence exists for some countries, many other countries lack epidemiological data. Also, disability seems to be a major research gap for all the countries in the region. Species identification is sometimes overlooked in medical records or not utilized to inform procurement of antivenoms. Thank you for listening.
Thank you. Well, I found that interesting. I hope the rest of you did as well. That's not specific, well, those data are specific to the EMRO region, but the general messages are ones that we find we're hearing from pretty much across the whole world, that in some countries there is good quality epidemiological data, in others it's very poor and there's none. And I particularly liked the way Dr. Shala emphasized the lack of information or good data on disabilities as well as cases and deaths. And again, if any of you know of good quality data on the disabilities in particular, we'd love to hear from you. So what we're planning next is a question and answer session, a very brief one, I'm afraid, only for 20 minutes or so. But just while we're getting ourselves sorted for that, we have a 5-minute video clip that Kaushi can share, which is from our friends and colleagues at the Madras Crocodile Bank Trust that Ganesha put together. Do you want to put that up? Thank you.
Yep, exactly.
And then I will introduce the panelists.
Prevention and preparedness are the 2 most important things when it comes to tackling snakebite, but it is a neglected problem in the region. A doctor in a small town in Assam has a potential solution that can easily be followed by other hospitals to effectively manage snakebite cases.
I'm Dr. Sudhin Giri. I work in the Demo Community Health Center. It is a government rural hospital, and basically I'm an anesthesiologist. Now, this MO, that is medical officers, they have to look after the delivery cases, they have to look after road traffic accidents, the fever cases, they have to look after the diarrhea cases, and every sort of patient they have to look after. We thought that we have to approach these victims in a holistic manner and in a systematic manner. So we created a 2-bedded snakebite room. Suppose the neurotoxic victim comes and there is only 1 doctor and 1 nurse even there, and there are many patients. We immediately shift the patient to the snakebite room. In the snakebite room, we keep all medications like adrenaline and anti-snake venom, calcium gluconate, neostigmine, ambubag, oxygen. Everything is level and this is displayed in the wall. And also there we have displayed that is the venomous snakes of Assam, which is available in our local area. So whenever the patient comes and they say, "Oh, sir, this is the snake, it has bitten me." So it becomes easier for us to treat those victims. Initially in the 2008 to, you can say, up to 2018. So in a yearly basis, around 10 or 12 cases came to the hospital after snake bite. So we went to the communities, small communities in our local area, and even in the interior of the village, the people are following the WhatsApp and the Facebook. So I am sharing my number as well as the stories, successful stories of the snake bite treatment in Assamese, that is circulated in the WhatsApp and the Facebook. And so that time people came around 10 to 12 or 15 numbers per year, but now 50 to 60 numbers of people per month attending the hospital, and that is why the death rate decreased in our local area.
তেতিয়া কিন্তু মোৰ ঘৰতে মই ভাবিছো যে মই বাচিম বুলি ভবা নাছিলো আৰু মুখখনো ফুলিলে আৰু মই উশাহ নিশাহ লোৱা কষ্ট পালো কষ্ট মানে উশাহটো ল'বই নোৱাৰিছিলো পানীটো কিন্তু খাব নোৱাৰো আপুনি মোক আনি দিলে আপুনি নোহোৱা হলে মই কিন্তু কেতিয়াও বাচি নাথাকো এই ল'ৰা ছোৱালীক নেদেখো আপোনালোকৰ মুখো নেদেখো চিটত দিলেগে ভেচলিন দিয়াৰ পিছত মই অলপমান হস্পিটেললৈ আহিলো আৰু মই এতিয়া আকৌ এখন ঘৰত আকৌ আহি পালো
Snakebite is a medical emergency and is a preventable and treatable disease, especially for those who are able to get medical treatment within the golden hour.
মই মেডিকেল কলেজে ভাল হৈ গলো আৰু সকলোকে কওঁ যেন সব মেডিকেললৈ যাওক আজিকালি ট্ৰিটমেণ্ট হয় চিন্তা কৰিব নালাগে মানুহ ভয় কৰিব নালাগে মৰিম বুলি মই চোন বাচি আহিলো একো নহয় বেজি ল'ব মানুহ সকলোৱে ভাল হৈ যাব
This is my special appeal to herpetologists, naturalists, and doctors, everyone interested in snakes. Let's all join together to help the rural communities affected by snakebite. Thank you.
Mike. Lovely. Thank you very much for sharing that, Kaushi. Ganeshra put that together on our request. I'm delighted he did so. It's just a wonderful case study. Now, we have a distinguished range of panelists. The names have just gone up on the screen. So please allow me to welcome Dr. Aniruddha Ghosh from the Ministry of Health in Bangladesh, Dr. Kolhero from the Ministry of Health in Cambodia, Dr. Ajit Shawala from Ministry of Health in India, Aya Yahima, who you've just met already from the CRO office, and David Williams, who you've also just heard of, who's currently in India working, but based in the Geneva office. So we have an eminent group of people. What we need now is questions from you, the audience. What do you want to hear from these people? While you're thinking, I've got one or two questions that I prepared, which hopefully will stimulate some conversation. And so allow me, if I may, I'm going to not ask every question of everybody because we just simply don't have the time. But I wonder if we could just start. Let's start with the first name on the list, Dr. Ghosh. What would you say is the current situation for snakebite in Bangladesh?
Well, I'm traveling. I hope you can hear me. Can you hear me?
We can hear you very well. Thank you. And thank you for taking the time to join.
Thank you. I will be answering that in different sections. First, the epidemiology. The estimated cases per year now in Bangladesh is 400,000 plus, with around 7,500 deaths. This is the national survey conducted in 2022. And specifically, we have found out that there are 10%, around 10% of the victim have the long-term disability, physical disability, and 2% suffer from some kind of psychological disability. In Bangladesh, the national guidelines for the management of snakebite has been prepared for medical doctors and nurses and paramedical professionals. It was updated in 2019, and trainings are now being provided both physically and online regularly. There are 24/7 hub and spoke model in operation, where the small centers are connected to the higher centers. Provision of initiation of treatment by antivenom, if needed at the sub-district level, is being promoted. The gap identified needs to be addressed, like the competency among the health professionals, like skills of intubation and providing respiratory support in neurotoxic snakebite is now a top agenda. Training module for manual for such provision of ALS and BLS has been finalized, and training of the trainers has been planned before large-scale training. And Bangladesh, regarding antivenom, Bangladesh do not produce antivenom yet, but these are imported from India. But the government has a plan to see the feasibility, followed by production of AB using venom from our local major species. We have a government-funded venom research center where we have collected almost all venomous snakes of Bangladesh known to us, and they are geographically tagged, and we have collected their venom. So we now have the venom, representative venom of all the venomous snakes of Bangladesh. And recently we have started a small project of producing antibody in goats and chicks against the venom of Russell's viper in from Bangladesh.
Thank you. That's a very delightfully comprehensive answer, and an impressive set of data you have there to back up your plans, which sound very exciting. I wondered if I might ask the same question from Dr. Hiro in Cambodia. Dr. Hiro, are you with us? Yes.
Okay. Thank you very much for inviting us from Cambodia to share our challenge that related to the snake bite in the country. Is it possible I can share my PowerPoint? No.
Yes, if it's a brief PowerPoint, just a couple of slides, that would be lovely. If it's a long PowerPoint, I'm afraid we don't have time.
Can you see my PowerPoint now?
Yes, we can.
Okay. This is a brief summary, that background that in Cambodia that we have Tele Mekong and Tele Sap, that most of our Cambodian population living in the flood-prone area. So that's why the snake bite, whenever the flooding season is coming, that snake bite can affect most of the population. Then also the Cambodia have some kind of forest that to make the snake bite can affect the Cambodia. That, and then I just would like to go a little bit faster, because the recommendation it can be the most. I would like to present the figure of the couple of years that related to the snake bite for the country. That as you can see that the total snake bite in 2021 and 22 is more than 3,000, and then the figure it can be underreported for some time, because that our geographical like information system is still under very low, and then so that for the measurement that we have the training material that we developed since 1990. But we trained 1999, and then we have updated some kind of training material based on that you can see that we have based on the venomous snake in the country, based on the sign in symptom assessment, diagnosis, and the management treatment. That's mostly the medical professional, doctor and nurse at the national hospital or district hospital, they are responsible to provide the management of the snake bite. And then we also have some kind of treatment local effect of snake bite, that this mostly related to the clinical. And then snake bite also affect the children and the pregnant women. And then usually we use resuscitation that by identifying, taking the critical ill patient, because you see that most of the patients they come to the hospital, it can be sometimes is in the late stage, and then mostly that we can provide the treatment through shock and through the some kind of experienced professional. That first aid is the common snake bite in the country as well. Then we also have some problem with the referral and transport for the patient. Then we have the snake bite. This that quite a long time that assisted by World Health Organization in develop the guideline in 1999, but it's 25 years already. So our current challenge is that as you're aware that very outdated guideline and training material also need updated. We also seeking about the update all the knowledge related to the snake bite management and community engagement is some kind of limitation. Our recommendation related to the snake bite that we would suggest WHO to assist us in terms of update of country assessment, healthcare accessibility analysis, training of health worker, review and update snake bite management guideline, as well as the community education. Thank you very brief. Thank you very much.
Thank you very much indeed. That's extremely helpful, and I have to say I'm impressed with what you're trying to do there, and I'm impressed with the commonalities again that are coming through here. The focus that you and Dr. Ghosh put on the training of people, for example. Dr. Shawala from India, India, you're working. You're
Okay.
working, yeah. The situation in India is one that there's a lot more literature about, if not only because you're such a large country. Rather than asking us sort of what the situation is now, I wonder about if you could share with us your experience of what's the best way to go about raising awareness and increasing access to resources for the treatments that we all agree on this call are so badly needed.
So, can you hear us?
Yes, we can.
Yeah, so we have with us our whole team, although we cannot switch on the video. Maybe some issue, connection issue. But we'd like to, I think Dr. Aya has already briefed her in slides about the India's initiatives with respect to the snakebite prevention and control. So the anti-snake venom is already a part of national essential drug list, and all the states and union territories, they have the anti-snake venom as a part of essential drug list. This is the first point. Secondly, in terms of having the accessibility of anti-venom, we have written to all the states that they should ensure the anti-snake venom at the lowest level, that is at primary health center level. And we are pushing the states to put the budget for the anti-snake venom under National Health Mission. That is the umbrella program for implementation at the state and district level. So last financial year, it was approved, and we are happy to share that most of the states are now budgeting a dedicated budget for snakebite prevention and control activities. So this has been a sea change in terms of financial resources. In terms of the educating the communities, we have asked the states to put up the budget for community awareness under this program. So as a part of overall umbrella budget of NHM, and states are now opting that. And today also, as a part of International Snakebite Awareness Day, different states are already celebrating this awareness day through various activities. Another point with the global action plan, by reducing the deaths by half by year 2030, we already developed a draft national action plan, and it has been developed with consultation with all the stakeholders, anti-venom manufacturers, the NGOs, government counterparts, Ministry of Wildlife, Forest and Climate Change, and the different ministries. So along with that, we have different for these anti-venom effectiveness. We have discussed the issue with the Ministry of Wildlife and Environment Forest Change, so that the not only the effectiveness but also the supply from the manufacturers needs to improve. So we had initial meetings with the anti-venom manufacturers and also with the DCGI, so that the regulations with related to the anti-venom and the milking of the snakes or the catching of the snakes, that needs to be that can be refined with respect to the actions which we have envisaged as a part of this national action plan. Another component is that we are in process of making this disease notifiable, and like one video you have shown from Assam, we want to develop the model snakebite centers for management across the country, and we will be initiating a separate budget for that. But at present, since last 1.5 years, the dedicated officers have been appointed under the states and districts to look after this activity. And we are very happy to share that most of the stakeholders are very receptive and had taken this agenda in very good faith. And we feel that with the involvement of this national action plan, we have planned next month all the stakeholders meeting. We will be endorsing in that and launching it in the next month, next month, so that implementation will start thereafter. So we are very pretty confident of achieving those within the timelines. And this is, I think, from our side. Over to you, please. Thank you.
Well, thank you very much indeed, Dr. Shawala. May I say, best of luck. I really hope it goes well, the launch of your National Action Plan. That's a really good, positive thing to hear. And if I may, I'd like to pick out one particular thing you mentioned there, this clever balance that needs to be found between distributing antivenom as far and wide into the communities where need it most, and yet it needs to be at a level where there is the clinical expertise on hand to make sure it's administered well. Difficult balance, I'm well aware of, and I'm delighted to hear the moves you're making in that direction. Okay, so I've seen no messages in the chat saying anyone has any burning questions. I apologize again for being a little late start, and I'm delighted that so many of you have been able to stay with us even though we've gone over the allotted hour. I'm very aware that we're all leading busy lives and people will have other meetings they need to go to. Indeed, Aya from the CRO office has already had to leave with her apologies, but at least we all heard the great work that she's doing there. So unless there's any burning last things that anyone wants to say, particularly if that is from Kaushi, who's the person who's organizing me and the rest of us, in which case, unless there is, Kaushi, are we okay? Thumbs up, down? Thumbs up. In which case, aye. Someone wanted to come in.
Yeah. So, Dr. Ajit, I just want to, we have seen some maps from the habitat suitability in the presentations by different countries. So we would like to have details on that so that we can prepare it for India.
Yes, certainly. That's an excellent suggestion. Thank you very much for that. Can we pick that up offline? That's not an easy one to answer in the here and now, but we would be very interested in working with you as best we're able to facilitate that. So please just drop an email to any of us, that's Kaushi, David, or myself, or Dimitra, and we will be able to respond and work that with you and with any other country representatives who are interested in working further on some maps. I believe one new message has come in. Right, okay. I think enough is enough. We all have to move on to other meetings. So please allow me to thank particularly the presenters, the speakers for this brief panel session, and particularly for yourselves, the participants, and on our collective behalf, all the other people out there who actually go about doing the daily work that actually saves lives. It's all the clinicians, all the people that are doing the community engagement work, everybody. They're the ones who are actually saving lives, and it's not me sitting in an office in Geneva, but I'm trying to do my small part in this grand, complicated process to make lives a little bit better, as are we all. And on that positive message, good luck. I hope everybody enjoys the rest of your working day. Okay, goodbye for now.